Yeah, please start, Doctor.
Good afternoon to everyone. Once again, I thank the organizers of PCSI 2021 for giving the opportunity to talk on this subject, muscular ventricular septal defect, negotiating the challenge. Muscular ventricular septal defects account for approximately 10 to 15% of all VSDs. It may be congenital or occurred. According to location, muscular VSDs are classified into apical, mid-septal, anterior, posterior, and Swiss cheese defects. And occurred may be due to myocardial infarction or trauma. The decades VSDs were when done by the surgeon, and of course they can do all type of VSDs, whether it is large, small, whether deficit trim, all those things. But coming to the muscular VSDs, they were having a lot of problems. So like surgical repair of muscular VSDs continues to be associated with significant long-term morbidity and mortality. Surgical right and right ventricular approaches provide suboptimal isolation of the defects due to heavy right ventricular tuberculations. Left ventricular atomy gives good exposure, but it is associated with apical aneurysm, ventricular dysfunction, and sometimes necessitating heart transplantation. So significant residual defects after surgical repair are observed mostly, in children, infants, and also Swiss cheese type of VSDs. So because of all these, some of these drawbacks, our intervention like periventricular and percutaneous and periventricular interventions are evolved. Because indications, heart failure not controlled with medical therapy, left to right strand of QPQS ratio more than 1.5, left heart volume overload, history of previous endocarditis, and development of developing pulmonary hypertension. For contraindications, body weight of less than 6 kg, for all this may vary according to the operator's experience. PVR index of greater than 7 units split up following vasodilator therapy like oxygen. Presence of additional defects which requiring surgical intervention, of course, parents' preference to surgical intervention. Of course, most of the VSD muscularis can be defined by TTE, but 4-chamber Ferguson long action short XVs provide adequate plans to determine the location of the muscular VSDs. Paracetamol short XV near the tip of the mitral valve delineates the location of the VSD. If the defect is located between 7 to 9 o'clock position, usually it will be a inlet ventricular septal defect. Mid-muscular region is there, probably, but you can see in the 9 to 12 o'clock position. If it is a 12 to 1 o'clock position, probably it's anterior defects. Because suppose you are not able to define the VSDs with a TTE, probably can go for other modality of imaging like 3D imaging and also cardiac CT imaging. This is especially useful in Swiss cheese type of VSDs. Device selection, device is usually selected 1 to 2 millimeter larger than the maximum diameter. Balloon sizing is not recommended because ventricular septum is not a structural structure. Because approach may be anti-grade approach, retrograde approach, or hybrid, that is perpendicular approach. Anti-grade approach may be a AV loop formation or direct crossing from the right ventricle to the left ventricle. AV looping may be a femoral artery to femoral venous approach or femoral artery to jugular venous approach. Because retrograde from the femoral artery. Suppose a very small child, it's difficult to, chance of vascular is very high. And if you want to avoid a pump, probably a perpendicular approach will be a best choice. Because there are a lot of devices choice are available for muscular VSDs. Of course, muscular VSD occluder, ampacid duct occluder 1, conar MF VSD occluder, ADO 1, post MI VSD device, VSD device. Of course, there are some coils also available. Duct occluder 1 is useful whenever septal thickness is more than 7 to 10 mm because the risk of the RV risk of ampacid muscular VSD may not expand if its length is more than 7. Because crossing the VSD, VS is crossed from the left ventricle or from the right ventricle. From the left ventricle, you can cross like just floating technique. From RV or LV, you can use the catheters such as Judkins right catheter. Probably most of them we can use this. We can cross with this JR. Sometimes, especially anterior muscular VSD, we need a cut pigtail or some other catheters like Cobra catheter. Arteriovenous guide wire loop. An exchange guide wire like thermo or a noodle wire is blocked in the left or right pulmonary artery or sometimes in the SVC. Undue tension on the AV loop to be avoided, it may cause rhythm disturbances or hemodynamic instability. To avoid direct contact to the contact of the guide wire with the VSD, a kissing catheter technique should be used. Derivation may be kept in the left ventricular area, descending rate according depends on the location of the VSD. Device deployment. It may be antegrade approach. LV disc is deployed within the LV chamber or descending rate that depends on the location of the VSD. Waist of the device or right ventricle disc are then deployed. Retrograde approach, because RV disc is deployed from the RV chamber. Good positioning and the stability of the device is important. Of course, avoid potential compromise of the adjusting structures. Confirmation of the correct position should be established using a TT or a TE, and the restoration can be confirmed by using the angiography. So I'm going to give some few video clips of examples of various approaches for the device closure of muscular VSD. So number one, so it's 8 months old female child with large mid-muscular VSD of 7 mm. So this is a AV loop technique approach through a femoral vein. So catheter is blocked in the left ventricle cavity. Then take the appropriate size device here. We use the 8 mm device. Let's pull it and then we can do angiogram from the artery side. Then release it off. Because be careful, you have to take the pigtail up, then release it off. Sometimes the pigtail gets stuck in the device, it may pull out. So be very careful when you're better to take the pigtail out and then release the device. Second case is a 9 months old female with mid-muscular VSD of a large size. Here I did not puncture artery, we just use the pigtail, then inject and then cross the VSD from the RV to LV, then from the femoral vein deployed. Third case is a 7 years old female, of course, large mid-muscular VSD. You can see the thick septum. Of course, this was must meet and apical region, so we plan to do procedure from the jugular venous approach. So AV looping, and then cross the sheath from the jugular venous. Yeah, this is a long. So injection through the sheath, confirm there is no leak by echo also, then release the device. Then another 7.5 months old child with a mid-muscular VSD, large. So initially we thought of approaching through antegrade. We are able to cross the sheath, but after once wire was taken out, we did not sheath stand there. It came out, so we reverted back to the jugular venous approach. So you can see that because of the thick septum on the RV side of the RV disc was not open fully, but anyhow, it's completely closed, so we just left it as. Then case number 5. This is a posterior muscular VSD high in the basal region. Of course, we use the Judkins right catheter to cross the VSD. So antegrade technique, sorry, retrograde technique. Just cross the VSD from the pass on the sheath from the artery side, So then push it, check with the angio from the, or we inject the contrast from the RV side with the Berman catheter, then check the shunt through lever phase. After injecting, better take the sheath out, otherwise sometimes the residual shunt is there or leak from the catheter. So we normally take the inject the catheter out from the RV and then check for the lever phase. Then here's some 6 or 10 years old female with large VSD, muscular VSD. Here, of course, just this is floating wire technique. So just keep the wire there because of the pressure push from the LV side, it gets crossed into the VSD to LV, RV. Because this is also retrograde approach. So inject from the RV or PA, then check for the lever phase, then release it off. So this is another, this is anti-muscular VSD. Sometimes the crossing is from problem. So here you have to use a different catheter. We use your cut pigtail. So to cross it. So then inject from the similarly from the RV PSI. So check for the lever phase any residual shunt. Just release it off. And then the last case, a 5 years old male child with apical muscular VSD. Of course, there are a lot of two number. So we just cross from the LV side, trying to deploy retrogradely. Okay, so there is actually one more defect probably we are planning to do in the next sitting. For some reason we have to consult them. So what are the complications we can see this muscular VSD waist closures? So device embolizations, any other device. So the chance of their reported data is 2%. If it's embolized, you should have the total hardware, some surgical backup. Dysarthrias, a segment branch is common. And computer blocks more common in terminal VSD, but sometimes can happen in muscular VSD also. The reason for the computer block are direct compression by trauma, by the wire and sheath. So you have to be careful, manipulation of the sheath and wire should be careful. So pressure of radial forces of the device, clamping force of the device, inflammatory process, use of oversized device, all are the reasons for the computer block. Of course, valvular malfunction, mostly here muscular VSD problem, tricuspid is the mostly, especially the high posterior muscular VSD. If you are implanting, probably it may impinge on the tricuspid valve and may create the tricuspid valve regurgitation. Hemolysis, whenever there is a residual shunt, so if it is a mild residual shunt, a small residual shunt, the urine color is less, probably can leave it and observe. This can be self-limited. If it's a massive hemolysis, probably needs blood transfusion, it has to be removed off. So whatever challenge you can observe from the beginning, the diagnosis, probably muscular VSD is not a one plane, so there's multiple, you have to evaluate fully because location very important, whether it's basal region or mid muscular region or apical muscular region. Size very important because muscular is sometimes lower, many times will be underestimated. Number of defects, sometimes we see echo, even angio is also a single defect, and after closing one, we can see that another one will be coming up. So number of exit, maybe there are one entry, there will be multiple exits. Okay, 2 minutes. So our approach probably AV looping. So AV loop may cause hemorrhagic instability when long stiff sheath and is placed across the tricuspid valve. May also cause rhythm abnormalities. So suppose sheath doesn't cross the VSD, the possibilities are wire and sheath have gone through the cardi. Separate sheath got stuck in the heavily tabulated septum, because sometimes may pass through the one of the smallest exits of the VSD, which has got multiple exits. So, or sometimes kinking can occur. If that is the case, you can better always use the braided sheath. So sometimes multiple VSDs, we think only one, after closing the one, then we can see the another VSD. So you have to close it up. Technical, probably inability of the device to deploy, because RV disc may not expand because of the thick tuberculations. So in that case, use the ADO1, because ADO leakage, as I mentioned, Titus problem is the problem. Can suppose in case a significant problem, you have to retrieve it and redo the procedure. If there's a mild tricuspidation problem, you can leave it, not be any problem. So residual shunt, probably hemolysis is the one, and if it's a mild, probably can leave it. With significant, probably you have to. If it's a large residual shunt, you can go and do one more, put up one more device and come. Otherwise, take it out and send for surgery. Of course, maybe classify this residual shunt as trivial, small, moderate, and large based on the width of the color width of the shunt, residual shunt. Because complications, yes, here embolism is another serious complication. So device to be loaded underwater. Because conduction disturbance can be after the muscular device closure. So avoid undue tension on the wire and sheath, and careful manipulation of the catheter to be done. Both right bundle block, complete heart block after percutaneous muscular VSD device reported. Because RBBs may not be a problem, but complete heart block is a problem. Okay, so careful catheter manipulation is important. So take home message. If it is age less than 1 year, use more than 5 French sheath, use the antegrade approach. Location, if it's a mid and above mid-muscular or basal region, probably femoral venous approach or retractable approach. If it is a mid-muscular or a apical region, probably use the jugular venous approach or retractable approach. And the heavy trabeculations, probably you can use the ADO1. And of course, difficult to negotiate the sheath, probably one of the three causes I mentioned, probably you made a conductard or maybe have stuck in the trabeculations, or maybe you want to this one of the smallest exit of the multiple exit VSDs. So you have to take it and redo the procedure of the whole. Thank you.
Thank you, Dr. Kalyanasundaram, for a beautiful presentation. I think we can have